if a person is uncertain of their prognosis, or if a provider is uncertain of the goals that the patient has for themselves, that might be an appropriate time to consider palliative consultation. The take-home message, though, is that the sooner that palliative care is involved, the more likely the patient and family are to benefit from the aforementioned outcomes.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Lenise Taylor, Oncology Clinical Specialist at ONS. Today we're talking with Carey Ramirez, nurse practitioner and manager of advanced practice and supportive care medicine at the City of Hope National Medical Center in Duarte, California, about what oncology nurses should know about how we can increase access to timely oncology palliative care through the use of telehealth. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining us today, Carey.
Thank you. Good morning. How are you?
I'm doing wonderfully. And yourself?
I'm excellent. Thank you.
All right, let's get started. I want to start by asking, what is the best time for patients with cancer to begin palliative care, and why is that timing so important?
Palliative care is an important service offered to patients and families. The data supports palliative care referral at diagnosis of stage 4 disease. This can impact them in several ways. First and foremost, it helps improve any pain or symptoms that need to be managed. Patients typically have improved mood, lower rates of depression, improved patient satisfaction, and even improved survival. In addition, we find that there's decreased utilization of healthcare resources, particularly as patients approach end of life. We must acknowledge, though, that there are nuances that affect timing, and they are often dependent upon resources in your community. City of Hope, for example, and other well-resourced urban medical centers often have large supportive medicine programs, and they have the ability to see patients sooner. There are other centers, though, that might have fewer resources and/or rural communities which may not have adequate availability of palliative providers to make that referral to palliative care at diagnosis possible. In these scenarios, we often recommend triggers that should be considered. For example, if a person is uncertain of their prognosis, or if a provider is uncertain of the goals that the patient has for themselves, that might be an appropriate time to consider palliative consultation. We might also see that a person who's frequently hospitalized, or having weight loss, or is having pain or symptom management issues that are not easily met by their primary oncologist. These are all important considerations for triggers that might make palliative a possibility for patients in those scenarios. The take-home message, though, is that the sooner that palliative care is involved, the more likely the patient and family are to benefit from the aforementioned outcomes.
We know that patients can face barriers from a variety of levels, personal, provider, or systemic, that may delay their access to palliative care. What are some of those primary barriers you've seen from each of those levels?
It's important to stratify barriers into different buckets. It helps us to understand where to apply resources to overcome those barriers. From a patient and family perspective, we frequently find that there are misperceptions regarding palliative care. Oftentimes, they'll conflate the word palliative with either hospice or end-of-life care. They unfortunately sometimes believe that they're one and the same. They demonstrate a lack of knowledge regarding the benefits, including the fact that palliative care can and should be provided alongside life-prolonging care. In addition, we find that they have a lack of prognostic awareness or concordance with their providers. This is essential and should be a foundation from which to work. And it happens for different reasons. Some families, for example, might protect their loved ones from full knowledge of their diagnosis or prognosis for fear that they might give up, or for fear that they might have increased anxiety. Some providers do an excellent job of sharing accurate prognostic information and are sometimes met with denial, which is a normal coping mechanism that palliative care can actually help them progress through. Many providers overestimate prognosis or forego conversations to achieve that concordance, and that can often be a barrier. There are also economic and logistical barriers. For example, we find that there's a maldistribution of palliative providers throughout the United States. We might see, for example, that in rural communities, there are fewer palliative providers to meet the needs. We might also find that there's a lack of transportation to or from palliative appointments. There may be long wait times for appointments or within waiting rooms for people who have functional disabilities or difficulties due to their disease or the treatment of it. So you can see that from patient and family barrier perspective, there's a bit for us to focus in on to try and make things easier for them. From a clinician perspective, the term palliative is often a barrier. It comes at times with negative stereotypes. A lot of places have gone to switching from palliative care to the words supportive care or supportive medicine because they have found that it's better received by patients and their loved ones. It's also better received by referring providers. Some providers also worry that they're decreasing a person's hope if they refer them to supportive medicine. And I'd like to reassure everyone on this podcast that palliative providers do their best to help patients maintain hope throughout their disease trajectory, regardless of how well or how poorly things are going. I tend to view things in terms of climbing a sand dune. For example, I talk to my patients and their loved ones, and I share that living with cancer can sometimes feel like you're walking up a sand dune, either at the beach or at the desert. And there will be days where you take 2 steps forward and you might slide only 1 step back. There may also be days where you take 2 steps forward and slide 3 steps back. And you find, for example, that if you keep trudging towards the top, that because the winds are constantly blowing those dunes, the top you eventually reach might be different than the one you initially set out to reach. And I think that speaks to the changing nature of hope. To put that into easier terms to understand, you might find, for example, that a stage 4 breast cancer patient who initially set out with the hope for cure eventually recognizes that it may not be possible and then adjusts their hope for reaching the college graduation of their son, for example. Or in a scenario in which that may not happen, have an early graduation party for their son that they can attend and be a meaningful part of. So those are examples of how palliative might help to maintain hope over time. I think other clinician barriers are similar to those of patient barriers. They might also conflate hospice with giving up. And there are often times when the provider might say, the patient's not quite ready for palliative care. Over the course of my career, I've come to hear that as well as I'm not ready to refer them to palliative care. So I think it's important for us to have a spirit of inquiry and to help ask questions to help us better understand that reluctance so that we can try and address it. As was true of patients, providers also have a lack of prognostic awareness or concordance. They sometimes have a difficult time conveying prognostic information to patients and families. They might also see that that patient or family is in denial or have a lack of understanding of their disease process, and at times might be less likely to accept a referral to palliative care as a result. I would like to remind those who are listening, however, that palliative care is adept at helping out in situations like that and can often build bridges and or open lines of communication and understanding that help get patients to a different level of understanding and appreciation of their prognostic awareness. I think it's also important to note that some patients might have unrealistic expectations of the prognosis or effectiveness of their treatment. The same holds true of their providers. One of the things we can't overlook is the lack of knowledge and training regarding palliative care. Providers still believe that palliative care may not be provided alongside life-prolonging care, or should only be provided within the last 3 months of life. Providers describe palliative care at times as simply pain management. Many providers still lack training regarding the value of palliative care, how to have difficult conversations or to deliver difficult news and or to discuss death. Finally, providers who lack knowledge on different components of palliative care are not able to convey those valuable components to patients. And so I'd like to remind everyone here that we can be helpful when pain and symptom management needs go beyond the expertise of the oncologist. If you find, for example, that you and your team are having a hard time managing psychosocial or spiritual issues, that's an important consideration for referral to palliative care. If you find, for example, that a shared decision-making approach culminating in a value-based care outcome would benefit the situation, i.e., there's disagreement between family members, disagreement between the family and the physician, disagreement between specialists taking care of a patient, those would also be appropriate times to get palliative involved. And finally, it's important to ensure that providers are aware of the local services available to them in their respective communities. I think these are some of the barriers that clinicians face, and there are many others. Let's get into the healthcare system barriers as well, though. We often find that from an organizational or a structural barrier perspective, there are lack of access to palliative care in the community. We often find that outpatient programs may not be as robust, or you may find that there's great variation between outpatient programs with regard to quality. Some communities lack inpatient beds for palliative care, and you might also find that programs may be located in inconvenient locations. So it's important for us to recognize that whether it's personal, provider, or systemic, there are multiple barriers for us to consider, and we should work together to more accurately assess those barriers so that we can come up with plans to overcome them.
Those are some excellent descriptions and some examples. I love that example of the sand dune. It is so apropos. What patient groups have you found have the most substantial disparities for equitable access to palliative care?
I would say that we have multiple patient populations who unfortunately do not have equal access to palliative care. They include rural populations, those who come from low socioeconomic backgrounds. We find that male patients and or patients who are older adults have lower access to palliative care. We find that those who might be either single or live alone, those who might have an immigrant status, those who don't speak English, those who might have certain cancer diagnoses. It may surprise some of you to know that those with hematologic malignancies actually have much lower rates of palliative referral than those with solid tumors. And that's something we certainly need to take a closer look at and work intentionally to build bridges with the hematologic community so that we can ensure that those patients have access. We also find that Black and Hispanic populations, those who might lack insurance or those who are underinsured, and those from LGBTQ plus communities also suffer from disparities with regard to access to palliative care.
I think you've touched on this already, but how are some of the social determinants of health involved, and how may we need to consider our own implicit biases working with patients with palliative care?
I tend to think of social determinants of health in different categories. With regard to economic stability, it's important to recognize that when a person lacks insurance or when they have an insurance that might not be the best of insurances, their access to palliative care might be limited. We might also see that for palliative organizations that charge copays, that for some patients that would make it difficult to move forward because they can't afford to pay the copay. We also frequently deal with scenarios in which we prescribe a medication that might be too expensive for the patient and then need to rotate to a different, more affordable medication. So these are issues of economic stability. We also find that there are issues surrounding education access and quality. When a person has low health literacy, for example, it may adversely affect their understanding of their diagnosis, their prognosis, their intent to life-prolonging therapy, and how palliative care may be helpful to them. So it's important for us to meet them where they're at. It's important for us to take the time to help them to understand each of those components so that we can work through them in a way that does not preclude them from access to palliative care. We also think in terms of healthcare access and quality and recognize, as I've said previously, that there's a maldistribution of palliative care resources nationwide. We tend to see that many of the resources are in urban areas, and as a result, we find that a great many rural areas are left untouched. I think it's important for us to recognize that these social determinants of health exist. It's important for us to look intentionally at them and whether they affect some of our patient populations and to work together to overcome them. I would say, in addition, the neighborhood and built environment within which someone lives makes a big difference in their ability to receive palliative care services. I often have thoughts of my time in New York City, for example, when patients had to take buses to and from appointments. You might see, for example, that a person is at risk when they live in a difficult neighborhood. Over the past several months, I've had a patient, for example, who has been robbed at gunpoint of his opioids in his unsafe home neighborhood. So these are very real and difficult scenarios in which people sometimes live. With regard to our own implicit biases, most implicit biases are unconscious or unintentional. It's imperative that we are self-reflective and recognize our own implicit biases. If, for example, we see a patient with low health literacy and choose to forego an offer for palliative care because we believe they will not have the wherewithal to understand how it may benefit them, or worry that they will not be able to handle conversations surrounding prognosis, we actually work to erode trust and may prevent them from benefiting from a service that may help them. People are actually quite resilient and wiser than we may sometimes believe. It's important for us to identify potential biases and to check them at the door. This will ensure that all people have access to the same beneficial services.
That is an excellent example. How is telehealth-based palliative care a solution?
Telehealth-based palliative care is an excellent solution. I'll say that the research is mixed to this point, but it's ongoing, particularly with the move toward telehealth brought on by COVID. Anecdotally, I've been doing telehealth for about 5 years, and it's been quite well received. It decreases my no-show rates. It improves my ability to monitor patients over time, and it can be carried out safely. For example, I've become increasingly comfortable with the use of telehealth by virtue of my ability to diagnose spinal cord compression via telehealth. This helps to make me feel better about the fact that I'm not missing red flag diagnoses. And so when I hear, for example, that a person has particular symptoms, I'm able to hone in on those symptoms and to recommend that they seek emergency department care right away and ensure that we're not missing diagnoses via telehealth. I would also add that the Veterans Administration does this quite well. They've been doing telehealth for longer than most private and or community organizations. Having worked at the VA for a short period of time, actually mail tablets to veterans who don't have access. And that was actually a big part of why it was successful. I'll also say that there are tangible benefits to telehealth-based palliative care. They improve access to palliative care for rural patients. The VA, for example, empowers veterans who live greater than 60 miles from a VA location to utilize telehealth for their care. It also assists patients with logistical difficulties getting to and from appointments. It might also save patients, providers, and payers money. From a space perspective at an institution, you also don't need as much clinic space to be available in order to move forward with a telehealth clinic. It also allows the provider instant access to home medications, any conditions they might be having, and needs that are specific to their home environment. We talked a little bit about the improvement in patient satisfaction earlier, but that cannot be stated enough. It also enhances our ability to monitor, communicate, counsel, provide psychotherapy for, and even in some cases provide rehab therapy for in a person's home environment. And finally, it improves access for underserved populations. It prevents escalation of symptoms and crises that might decrease ED utilization. And I will say that there is a major multi-center randomized controlled trial ongoing, and it's being carried out by Dr. Jennifer Temmel at Massachusetts General, which I believe will conclude in the coming months, and the collection of data will continue for a short time thereafter. I'm fully hopeful that this multi-center randomized controlled trial will help to substantiate a lot of what I've been seeing anecdotally with regard to the benefit of telehealth palliative care.
There's a lot in there, and I can't even imagine diagnosing spinal cord compression through telehealth. So that is amazing and so definitely needed so that we don't have to bring these patients in and get them directly to the care that they need. And just about timely access, be able to go back to their medications and pull those out in case they forget. We all know that people forget to bring their medication list in with them or it's not complete. So really good examples.
That's one of the great benefits is, if I'm talking about a particular medication and a person, for example, isn't sure which medication that is, I can have them go get their medicines and we can talk through the names of those medications, when they're supposed to take them, and also what those medications are for. I frequently encounter patients who are taking medications and have no idea why they're taking them.
So true. You mentioned a little bit about the research that is ongoing. What additional research is needed around palliative care and telehealth?
I think there has been quite a bit of research done on how to carry out telehealth. What we still need to look into are whether there are safety issues that we should be focusing in on and or worried about with regard to the provision of palliative care via telehealth. One of the things we just talked about was the diagnosis of spinal cord compression. That is considered an oncologic emergency. An argument against telehealth for palliative care or within the oncology community might be that we would miss a diagnosis like that. And so they would argue, for example, that that person should be seen in person and we should be able to carry out a neurologic exam in order to appropriately care for them. What I would say, though, is that as long as we're well versed in the symptoms associated with oncologic emergencies, we should be adept at asking appropriate questions to assess whether a person is experiencing that possibility. And if in fact they are, we can recommend that they go straight to an emergency department and or ETC, which is our evaluation and treatment center here at City of Hope, to have an MRI to rule it out. And so, in my estimation, we need to be doing research on some of the safety issues that could arise so that we can be intentional about completing plans to ensure that this care can be provided very safely.
What innovations or projects are nurses leading in the field of telehealth-based palliative care, and how can these be expanded?
That's a great question as well. A couple of things come to mind with regard to what we're doing here at City of Hope in particular. Approximately half of our initial consults and follow-up visits in supportive medicine are via telehealth. That includes both physicians and advanced practice providers. And we also have two of our nurse practitioners currently involved in collaborating to start a supportive medicine acute care clinic. And this offers a same-day walk-in or telehealth appointment for our cancer patients to address pain, symptoms, any psychosocial issues, etc. So I think it's important to recognize that telehealth can be utilized not only for a planned appointment that might be scheduled to surveil someone every 2 weeks or every month from a pain and symptom management perspective. It can also be utilized as a same-day possibility. So if, for example, we have a patient who's due to have an MRI tomorrow, and their last MRI was stopped in part because they couldn't tolerate it due to pain or symptoms, we might have a primary team reach out to us and ask whether we can see that patient the day prior to their MRI and devise a plan with that patient so that they can tolerate the MRI more easily the next day. And that might be an opportunity for us to schedule a same-day telehealth appointment to accomplish that goal. In addition, I'm working to start the first virtual fellowship to train nurse practitioners in remote locations regarding the art and science of palliative care. I think one of the main barriers that we have to access to palliative care is a shortage of providers, not only in urban locations, but also in rural locations. And so I'll be working in the coming years to establish a virtual fellowship that would allow me to train nurse practitioners in other remote locations via televideo. Televideo will also, for example, give me an opportunity to sit in on some of their patient visits with them or to participate in family meetings, therefore mentoring them in carrying those difficult goals of care conversations forward. So these are a few of the examples of the innovations or projects that nurses are leading in the field of telehealth.
That is so cool.
Yeah, I'm super excited about that, actually. It's been something I've been working on for the last year or so, and hopeful that I'll be able to have my first fellow within the program within probably 14 months or so.
I love the idea of being able to be alongside of them with that training. And I love the fact of how that's going to have such outreach into those rural areas and those areas with less access to care.
Yeah, me too. I think we have a maldistribution, as I shared earlier, of palliative providers. We really need to do our best to reach people who don't have access to palliative care in their communities. And this is an innovative way for us to do that.
Definitely. I'm going to back up just a little bit. You talked a little bit about routine check-ins with patients as they're undergoing treatment and are part of palliative care, your same-day visits or your pre-visits to help them through some sort of scenario. What other types of palliative care can be delivered through telehealth?
This is a great question as well. I think palliative care can be provided by providers. As we've already spoken about, these are people who are managing pain and symptoms. These are people who participate in discussions to ensure that patients have prognostic concordance with their providers. It's important, for example, that they're on the same page with regard to prognosis. I'll give you an example why. If a person believes that they have a 90% chance of cure, they will also likely want to go onto a breathing machine and or to endure many difficult interventions to try to get at that 90% chance of cure. If their provider, on the other hand, believes that they have a 0% chance of cure, it's important for the two to be in concordance. The reason that's imperative is because the patient would likely make different decisions with regard to the treatments they would endure if they had a more accurate understanding of their prognosis. And that might be a reason that a provider is involved to deliver telehealth palliative care. We also have other disciplines that can be very valuable with the delivery of palliative care via telehealth. They include social work. They can provide emotional support, logistical support. They can assist with financial resources. We also have spiritual care providers. Many of our patients no longer have the ability to get to and from their place of worship, and we can sometimes bring their clergy people to them via televideo. We also offer psychology services, psychiatry services, child life services, all via telehealth. And I think it's important to recognize that palliative care is actually made up of an interdisciplinary team, including all of the aforementioned specialists who can basically work together to improve the experience of the patient who's living with cancer and being treated for it.
What advice do you have for oncology nurses who want to develop a telehealth-based palliative care program for their patient community?
I would say that telehealth-based palliative programs do work. The evidence is pending, though anecdotally, I have developed relationships with patients via telehealth which rival those I've cultivated in person, and the outcomes are similar. It's important for you to make your case using the research that's already available. In other words, tout the research and the reach of telehealth, the logistical benefits of saved clinic space, the convenience for the patient to discuss their goals at home, and the improved patient satisfaction. It's important to build a coalition of influencers who see value in and may support your project. It's important for you to think outside the box and to speak directly to insurers who have a vested interest in meeting the needs of your patients at home rather than the more costly alternative of hospitalization. Finally, accept the inevitability of ups and downs. Learn from the downs and persevere. The outcomes are definitely worth it.
We talked a little bit earlier about the barriers to accessing palliative care early in cancer treatment, and I know there's legislation in Congress to address education related to this. Can you share more information about the Palliative Care and Hospice Education and Training Act, which we all call PCHETA, and how nurses can advocate for its passage?
I would say that if it's passed, PCHETA will create and promote education programs to expand the palliative care professional workforce. In addition, it'll support research on palliative care interventions and delivery and implement a public awareness campaign to educate the public on palliative care and its benefits. It's important for each of us to reach out to our congressperson via email, snail mail, or by phone to advocate for its passage. I'd also say that as nurses, we are the largest discipline within healthcare in the United States. So when we band together, there's power in numbers. So please consider joining organizations like ACHPN. These organizations actually lobby for things like PCHETA, and I'd remind each of you individually that collectively you make a difference.
Thank you. That is so true.
Yeah.
What's something about this topic that's not often discussed but you wish people knew more about?
I'd say that palliative care, when done well, has no interest in talking patients into or out of treatment, nor are we interested in obtaining control of the patient's medical care. Rather, we hope to get to know patients and their loved ones. We hope to learn more about their goals and values, and to advocate for them to receive treatments that lead to a quality of life that they would find meaningful. We hope for a shared decision-making approach leading to values-based care. In other words, we exist to help patients live life to its fullest despite their underlying illness or the treatment of it, and to live according to their own goals and values. And I think this flies in the face of some of the misperceptions that providers and or patients sometimes have about us. They might worry, for example, that we'd like to talk them out of treatment or that we'd like to talk them into giving up. And I just want to reassure everyone listening to this podcast that that is not the case. Our only goal is to honor patients and families by delivering a quality of life they would find meaningful. And that's different for everyone.
What additional training or education do oncology nurses need to further understand telehealth-based oncology palliative care?
There are several resources available. The first, and I think best known to me, is that of CAPC. That stands for the Center to Advance Palliative Care. They have a helpful website that you can Google or go to capc.org. It has information regarding setting up a program, preparing patients and families, as well as conducting telehealth visits. I think that would be the first place that I would start. And with regard to additional resources, I would also share that the NHPCO, the National Hospice and Palliative Care Organization, also has a website regarding the best practices for using telehealth and palliative care.
Are there additional resources for patients and providers who want to learn more?
Definitely. I would say that not only are CAPC and NHPCO possibilities, but I would look to Google to look for palliative organizations in your community, many of whom since COVID are now offering telehealth as opportunities. I will say that it's important for you to reach out to 2 or 3 of them if you live in a community that has 2 or 3 of them, and to build relationships so that you have a better understanding of who you're referring your patient to. In addition to that, you can also hold them accountable for some of the outcomes that they share that they're hoping to bring your patient toward. I would encourage you to reach out to palliative providers in your community.
Carey, this has been an awesome conversation. I've learned so much, and it's made me think so much as well. Do you have any final comments for our audience?
I do. I would say that I am a proud nurse speaking to many nurses with whom I share one of the most honorable professions on the planet. First, I'd like to thank you for the work you do for your patients around the country and for one another. Second, I'd like to empower you to harness your calling as a patient advocate. We do so in many ways every day. When it comes to palliative care, I encourage you to connect patients to this valuable resource, which is likely to benefit them greatly. For those of you who do not have easy access to palliative care services, consider answering the call by fortifying your own abilities to provide generalist palliative care or obtain referral to an interdisciplinary palliative care team via telehealth. Finally, I'd like to thank each and every one of you for what you do for our patients around the country every day.
Thank you so much.
You're welcome.
I hope you have a wonderful day.
Thank you. You too.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.